Thank you. Actually, if you're a customer of Synergistic, you get chili for Christmas every year. You get chili fixins. So we're going to have some fun today. We got 4 topics. One of them is different than what's in your outline. You have vulnerability management in there. I've switched that out for another topic because I thought it was more germane to what we're dealing with right now, and I thought it'd be more informational. So and that's after lunch, so I'll point you to that when we get there. Feel free to ask me questions throughout. If I get flustered, I'll give it to Adam, but I don't think that'll happen. But please ask me questions as we go. And you know, the secret to security is what? Come on, it's your first question of the day. Somebody knows that. What's the secret to security? Well, I wish that were true. What's the secret? Yeah. Now, the secret to security is readiness. Okay? You are never going to be 100% secure. There is no such animal. You're never going to have 100% secure systems. There's no such animal. You're never going to be completely ahead of the threat. It just doesn't happen, right? So the secret to security is really being ready. So with that in mind, I'm going to talk about a friend of mine. When I grew up in Texas, went to a military school as a cadet, went in the Marine Corps after that, spent 25 years in the Marine Corps in the federal government as an intel guy. And one of the things that one of the friends that I made along the way was a Catholic chaplain who was with me over in the Middle East a while back. And he used to do rounds with me at night when I would go check my snipers, and because the snipers belong to the intel guys in the Marine Corps. And so I went out. We would go out there every night, and I'd say, "Father, you don't have to go with me." And he'd say, "You know what? If you're going out there, I'm going out there." And he would every night. He went out there and talked to the Marines out there on the perimeter, which was really cool for them because whenever they saw him, they just felt better. They felt safer, right? Well, he's now retired, obviously, from the Navy, but he's still a Catholic chaplain, and he has a parish up in West Virginia. And one of the things he does is every Mass, he brings the children to the front of the church, and he has them sit on the steps at his feet. Now, everybody thinks he does that because he likes children. I know differently. He does that because when they're down there, their parents are looking at them, and they're looking at their parents. And what happens? They get quieter, right? And they actually sit there and they pay attention and they actually behave themselves a lot better. So it's kind of, there's some method to the madness. But the other thing he does with the kids is every time they give something out, he has the children hand it out, which kind of gives them something to do, and they really think that's cool. So about 2 years ago, the Catholic Church came out with a little card, right, that if you got in trouble, if you got into a car accident or whatever, it was a 911 card, and it basically said, "I'm a Catholic, call a priest." Right? So the first responders would know who to call if you needed it. So he hands these cards out to the kids during that Mass to go hand out to the folks in the pews. And this little girl, she's about this tall, she takes about 3 steps away and she stops, and she's got this look on her face like she doesn't really know what to do. And he walks down and he says, what's the matter? And she says, well, our card says, "I'm a Catholic, call a priest. What does your card say?" And he says, "It's real simple. Call 911, right? Call emergency. Okay, I need somebody to help me get up and get well." So it's all about being ready. So we're going to talk about the Omnibus Rule first. How many folks have heard any presentations on the Omnibus Rule? A couple of you? Okay, I'm not going to go way down in the weeds on this thing because we could spend literally 4 or 5 hours just talking about the Omnibus Rule alone and the changes that it's going to bring about. But I'm going to talk about the big changes that are in there that you need to be aware of. How many people know that the Omnibus Rule is in effect already? Right? Went into effect on March the 26th. So we're already supposed to be compliant with the changes that are in that rule. When do we start enforcing that rule? In September, right? Real important. Now, there's a little known fact here, though, and that is that HIPAA violations or anything that's related to these rules has no statute of limitations, right? So that doesn't mean we've got till September to start doing things. Keep that, remember that. Okay? All right, get rid of that guy. So let's talk about the rule. Came out of the High-Tech Act. As you know, in 2009, there were multiple things that High-Tech brought about that were changes for the HIPAA privacy and security rules. Initially, they started coming out with the rules in a piecemeal fashion, if you recall, the breach notification rule, the enforcement rule, etc. And everybody in the community complained, essentially, and said, hey, quit piecemealing this stuff. Why don't you bring it all out at once and make it easy for us so we can make one change and get on with life instead of having to make changes every so many months, which made a lot of sense. That's where the Omnibus Rule came from. Basically what they did was they took multiple changes out of high-tech and rolled it into one rule instead of having a separate rule for each and everything that high-tech was changing. Okay? Now, there is one exception to the enforcement, and that is for business associate agreements that were already in place prior to January the 25th, right? Those you have until September the 22nd, although it says 23rd, it's actually the 22nd of 2014 to update. Okay? If you have a new business associate, or if you revise a business associate agreement, or you renew a business associate contract anytime after July or January 25th of this year, that particular agreement has to be updated to the new provision and has to be compliant by this September. But if you have business associate agreements that are in place now that you feel are compliant, right, you don't have to update those until next year. So you have extra time to deal with it. All right, talks about multiple changes from high-tech. It incorporates GINA into it as well. GINA is the genetic rule, the genetic information rule. That rule wasn't part of high-tech. There's some other rules out there like SAMHSA and CLIA and the common rule, and I'll talk about those as well. Those are not part of high-tech either, but those are also being brought into alignment with HIPAA, and that's literally what they did here. They basically brought GINA into the Omnibus Rule to bring it in sync with the rest of the HIPAA provisions around information. It implements changes to breach, privacy, security, and enforcement rules. And really, for the most part, there are little deviation from the NPR-M that we saw earlier last year. So let's talk about breach notification first. Breach notification is totally different now than it was before. In some respects, and in other respects, it's very similar. So, you probably know, or probably have heard by now, that the harm provision that was existing in the old rule is gone. It's not about harm as it relates to proving harm. It is about harm as it relates to the risk analysis process that's associated with breach notification. But now what happens when we lose control of PHI, or PHI goes to the wrong person, what have you, it is automatically a breach. Under the old rule, if you recall, it wasn't a breach until you proved that there was harm. Under the new rule, when you lose control of it, it's automatically a breach. Right? But you don't have to notify if there was a low probability of compromise. Now what this does is it changes the whole way we approach it, and it brings it into alignment with other regulatory programs in other industries. So if you look at how the federal government does it, if you look at how the banking sector does it, etc., their breach rules are very much like the new breach rule that we now have in healthcare. It's all about compromise, right? And I'm going to go through and explain and give some examples of that. But the bottom line is, the minute we lose control of it, it's automatically a breach. It's presumed to be reportable until we prove that there was a low probability of compromise and harm does not enter into the equation. Okay, how do we demonstrate a low probability of compromise? Well, we conduct a risk analysis, and there are 4 questions that they say we need to answer. Okay? Now, first of all, there's also a change in the new rule from the old rule in that under the old rule, anytime you had an incident, you automatically had to conduct a risk assessment and document it. Under the new rule, you do not have to do that if you decide right out of the gate to notify. So in other words, if you look at the incident and you say this is a breach and we're going to notify everybody, you don't have to do a risk analysis. Okay? But if you look at it and you say, I'm not sure whether we need to notify, or I don't think we need to notify, then you have to do the risk assessment and you have to document. Okay? When you do that, there are 4 factors that they ask us to consider. The first one is the nature and the extent of the PHI involved. In other words, was it just a list of names and addresses, or a list of names and departments, or was it a complete medical record? Did it include Social Security information? Did it include mental health information? Did it include more information? How many records were involved? Was it one record, a single incidence of a record gone to the wrong address, or was it 20,000 records on a laptop that just disappeared? Right? So it's the extent and the type of information first that we need to determine with respect to the breach. The second one is, who did this information go to? Did it go to another provider who knows how to handle the information, who calls us up and says, hey, I got this, but I don't think it was for me, I'm going to go ahead and delete it? Probably a pretty low chance of compromise there, right? Or did it go to somebody outside of healthcare? Or did it go somewhere where we don't even know where it went, and we can't even address the probability of compromise? Right? 2 different situations. Whether the PHI was actually acquired or viewed, and what the person, actually another part of this is, what did the person do with it? So in other words, when that person got it, whoever received it, what did they do with it? Right? If that provider we just talked about got it and called us and said, I got this, I know I shouldn't have gotten it, I'm going to delete it, we know what happened to it. If that same provider received it and then passed it along to somebody else, what do we have there? We have compromise, right? Because the rule says that it's okay for an inadvertent disclosure one-off, but if that person starts passing it along, now we've gone beyond that and we actually have a compromise, okay? Or did it go to somebody again that we don't know and what they might have done with it, or did it go to somebody who used it for identity theft purposes, etc. And last but not least, the extent of mitigation that might have been present with respect to the issue. And in this case, if it went to the wrong address, but it was transmitted securely to that location, the physician got it, said, this isn't mine, I'm going to delete it. So basically we can determine that the information was protected in transit. We know what happened to it at the other end and who had it. Again, low instance of probability of compromise, right? The laptop that was lost was not encrypted and didn't have password protection on it. No mitigation, right? We can't vouch for whether or not that laptop was potentially compromised. So I'm going to give you a real-world example, and I get these all the time. So hospital called me up literally the day after the new rule was released in January. And they said, we had a breach. We lost a laptop. The laptop wasn't encrypted. The laptop didn't have password protection. So basically the laptop was wide open. The laptop had been used by 20 to 30 physicians over the last 3 years. The laptop interfaced with their primary mental health application, where they kept all their mental health data. There were 1,400 records in that application that this laptop accessed. And there were multiple records on the laptop itself that the physicians had put there over time. But nobody knew exactly how many records were on that laptop. Okay? The laptop is gone. They don't know where it went. They don't know who has it. They don't know what the outcome of it is. All they know is that it's not protected. So if we go through this example, right, the nature and the extent of PHI involved, what do you have to assume in that circumstance? That there might have been 1,400 records on there, right? Or at least more than 500. So I probably have a reportable incident here. Second one, who did it go to? Who's got that laptop? We have no clue. It just disappeared. What did they do with it? We still don't know. Was there anything on that laptop to protect those records? Nothing, right? So if that incident happened at your facility and you had to use the new process to evaluate whether or not you should notify, where would you come down? How many folks would notify? Okay, if you didn't say yes, you're wrong. All right? Now let's take the old rule. The old rule says that I don't report immediately unless I have more than 500 records involved, and I have to prove that there was a chance of, or a significant chance of harm to the individuals. Now, if I look at the incident where I have a laptop that potentially I have hundreds of records on that involve mental health information, I would think that you would come down on the side that the potential for harm could be pretty high, right? Because the location I didn't tell you, which I'm not going to, but the point, let me put it this way. If there are 1,400 folks with mental health issues in this location, it's probably a good portion of the population, okay? So chances are, if you got that laptop, you unfortunately know way more than you need to know about a lot of people, okay? So it could be pretty damaging, pretty damaging. It's not encrypted, so it doesn't meet safe harbor, right? So notification is required from that perspective. But we don't know how many records exactly are on that laptop. So would you report it under the old rules or not? How many people would report it? How many people think that the hospital involved reported it? They did not. They opted to use the old rule, which, by the way, you can still do up until September, because technically they're not going to enforce it until then, as long as you report it before September. So in other words, if a breach happens now or sometime before September and you don't report it until after September, the new rule is in effect. So it's based on when you report, okay? So that's your one out right now, is that you have several months to get used to this new system and to adjust how you're doing things before they're actually going to start grading you, right? But if you're not already doing that, you need to start doing it. You need to start thinking this way. You need to start getting your organization thinking this way, because that's the way it's going to be after September, okay? You want to know the whole story? All right, I'll tell you the Paul Harvey version. So she asked me what the compliance officer asked me what she should do, and I said, well, I'm not going to let you off the hook. I said, you need to report this. I said, based on the facts that you've given me, there's no way in my mind that you can assess that there is not a chance that these people's information could potentially be compromised. Because whoever got that laptop, the minute they open it up and turn it on, they've got access to the information, because there's no encryption and there's no password protection. I mean, literally, it's wide open. So, and I got to believe that whoever took it, right, is looking at what's on it. Just human nature. Now, they may not have, but 9 times out of 10, they're looking at it. So I have to believe that somebody's information is at risk here, right? Now, whether it's 10 or 20 or 500 or 1,400, I don't know what the number is, but what I do know is that if you don't report it, and that laptop gets found, right, which we have had laptops be recovered, and the police get them, and then the police look at them, and then the police tell everybody what's on the laptop, and guess what happens? You really get egg in your face, because now everybody knows that you didn't notify, right, and you knew you lost the thing. So it looks like you covered it up. So it's 10 times worse than if you just notified right out that you lost the information. And in fact, human nature is, and the history is of incidents is, that those organizations that immediately report and take responsibility have almost zero impact. Those organizations that don't have tremendous impact, right? So it's like what your mother used to tell you, right? If you come and tell me when you screw up, it's not near as bad as when they come and tell me when you screw up, right? So Be the one that can be it. Be a man or a woman about it and stand up there and take responsibility for what happened and report. The fact of the matter is, and I hate to say it, but very little happens to those who are honest. People appreciate honesty, right? And they appreciate responsibility. What they don't appreciate is when we cover things up, or when we lie to them, or when we don't do the things that they expect us to do, right? That's when they get upset. That's when the consumer gets mad. So start applying. You should have already rewritten your incident response process by now. You should have already rewritten your notification procedures as it relates to this, and you should already be applying these 4 questions when you start looking at incidents, whether they're individual incidents or larger breaches. And if you're not doing that, I encourage you to do it so that you get used to it before September gets here and they start grading us on it. Okay? Notifications, for the most part, didn't change. If it's over 500 records, we still have to report it without delay as soon as we are aware of it within 60 days. For notifications of breaches smaller than 500, we did have a couple of changes. The first one is that, as you know, you can either report those right away or you can wait and report those within 60 days of the end of the calendar year, right? But what the old rule said was, it said in which the breach happened, right? The new rule says in which the breach was discovered. So if you have a breach in December, but you don't discover it until January, it's not reportable in the year before when it happened. It's reportable in the year that you discovered it. Okay? So if you discover a breach today, it's reportable in 2013 or by end of February 2014. What it amounts to. The other thing that they're doing, as anybody who's had to report breaches knows, that you have to do them individually on their website, right? Which is a real pain in the kazoo when you're doing the smaller breaches, especially if you're doing it at the end of the year. So one of the things that OCR is looking at is coming up with methods that will allow you to upload multiple breaches at like a list of breaches, as opposed to having to go in and do each one individually, to make it easier for folks to do that. Under 500 records, there is no requirement to notify. Right? Now, a lot of folks do that, and they use the same letter that they would use if it was a larger breach. But the fact of the matter is that under 500, there is no requirement for you to notify. Okay? Although the other thing that you all know, I'm sure that this is the report to HHS. You still have to report to media and the individuals, et cetera, and you have to do that prior to the report to HHS. Right? Let's talk about some of the privacy updates. There were lots of privacy updates in the Omnibus Rule. The first one here deals with fundraising. We got kind of a reprieve here, and then we got kind of a hammer. So the reprieve was that under the old fundraising rule, if you recall, there was only one type of information that essentially you could use for fundraising. Under the new rule, they've expanded it to additional categories of information that you can use in fundraising activities to make it easier for folks to do fundraising, which was a good idea. But the one other thing that they did was they said you have to have a very prominent opt-out provision in your fundraising going forward. It has to be conspicuous. In other words, it can't be like the banking industry where when you get your credit card, on the back side of it there's that little bitty print that you have to have a magnifying glass to read, and in there somewhere it says you have the right to opt out. In healthcare, that right to opt out has to be in big bold letters so that the patient can't miss it. Right? So if you want to do fundraising, you now have more information that you can use for that purpose, but you have to have a very prominent and conspicuous opt-out provision in those letters or whatever it is you're using to request dollars from individuals for fundraising purposes. If a person opts out, this is real important. If a person opts out of fundraising, you have to make sure that nobody goes back to them and asks them again. Okay? If you ask them again after they have opted out, you violate the privacy rule. Okay? Now, what you can do, the rule does give you the permission to put an opt-in process in that same letter. So in other words, you can, right next to your conspicuous, you have the right to opt out, you can also put a statement in there that says you also have the right to opt back in whenever you would like to. But you can't talk to them about that, and you can't address that with them after they've opted out. And that's real important. So whoever's doing the fundraising, which usually is the foundations, right, they need to have very good processes in place that when somebody opts out, that those individuals are identified and that they're not recontacted. Very important. Okay? It also has to be prominently posted on your notice of privacy practice, which is going to have to be redone. So let's talk about marketing. And I'm not going to go into this one in a lot of detail because it is still even confusing to me. And I think the lawyers are going to be arguing about this one for about the next 6 years. The marketing, basically for marketing, the real common denominator here for you to think about is that anytime you're using information or you have a relationship with an outside vendor for marketing purposes, you cannot receive money for that marketing in any form. So in other words, they can't pay for the marketing if they offer. So in other words, sometimes the vendor will come to you and say, we'd like you to promote our product. We'll pay for the marketing and do the campaign. Can't do that. That's the same thing as you receiving money. Right? It's the same thing. So if there's any remuneration or receipt of money in any form on your part for marketing, it's probably prohibited. Now, I say probably because there are exceptions in the marketing rule. And there are actually exceptions to the exceptions, right? So under certain conditions, we can market certain information and receive support from vendors as it relates to certain TP&O processes. We can actually remarket drugs from a prescription refill perspective, and that's okay. But we can't sell a new drug for a vendor or market a new drug for a vendor and have them pay for the marketing. Something you're going to want your legal folks and whoever's handling marketing to look at very closely in terms of all your relationships from a marketing perspective.
When you say that the vendor can't pay the facility for marketing their product, does that mean cash, or does that mean
no.
they come in and say there's a free line?
Can't do that. You receive any value whatsoever, it's not allowed. Okay? All right. I think the next one everybody understands with respect to resale of PHI. For the most part, covered entities are prohibited from profiting from PHI, meaning we can't sell PHI and make a profit on it. What we are allowed to do is to recover cost associated with having to produce or provide PHI. So for instance, if a patient requests a copy of their record or an accounting of disclosure or what have you, and we have to produce the PHI, we can recover the cost of having to produce that for them, right? But we can't sell it and make a profit on it. We can't profit from that enterprise. We can't sell our information to a vendor, for instance, who wants to use it for research purposes. We can't profit from the PHI that we have. And so that's really the key here. When you start looking at resale of PHI, if there's profit involved, we're probably on the wrong side of that rule. And that's what we need to think about. Now, there's some exceptions to this one as well. So for instance, if our hospital is being sold, the PHI that we have in our databases can actually be considered as part of the value of the organization when we sell it. So in other words, we can make money on it from an M&A process when we're selling our entity to somebody else as part of that sale, but not selling the information directly. And there are certain other exclusions that relate to things like accounting for disclosure and patient requests for records. The real key, though, as I said, is always around, are we making a profit from this? And if we are, something's not right. Okay? Research. Multiple changes to research. When researchers come in and request authorizations for PHI for research purposes. Under the old rule, you might recall that a researcher had to submit a separate request for every single research project that they did. So in other words, if I was doing one project today or this week, when I completed that research project, even if I was going to use that same set of data for a follow-on research project, I had to come back and get another authorization to do that. I couldn't do follow-on work. Under the new rule, they've made it easier for researchers to do multiple projects with a single authorization. Basically what they've said is it makes sense that when you start particular studies, there will be other studies that come out of that, and instead of having to go back and go through this process of this paper drill of getting authorization, as long as in the first request we are, again, conspicuous with respect to what we're going to be doing, meaning we say there will be follow-on research projects related to this project, we can ask for an authorization to allow us to do that without having to come back and get another authorization from the organization and potentially from the patients. Okay? All right. As of now, if you've been dead more than 50 years, HIPAA no longer cares about you. You are now history. Okay? Meaning, if decedent information for individuals who have been dead more than 50 years, it is not HIPAA covered, it's not PHI anymore. It's historical information. So the researchers are happy about that, and the history professors and all the other folks who want to know the history of different people and study those kinds of things, because now they don't have to go through the rigmarole of getting authorizations to get access to that information. For recently deceased individuals, the rules have also changed with respect to release of information to individuals that were part of their care. So under the old rule, an individual had to actually tell you who you could release their information to after they were gone, right? It had to be a formal process ahead of time. Under the new rule, they don't have to do that. In fact, what they have to do under the new rule, if they want to, is tell you who not to give their information to. In other words, establish a restriction. But with respect to releases or disclosures, anybody that was part of their care team while they were still living is authorized to receive information about them after they're gone. What you have to do is be able to prove in some fashion that they were part of that care team. So for instance, if you had an individual who was routinely picking up prescriptions for their parents, or for instance, in my case, I don't even know what all the forms are that I have signed, but for my parents, I have complete control of them when they go in the hospital, right? I mean, I can see everything. I can make the decision whether we plug them or unplug them, the whole 9 yards, right? And I had to sign all those things, and they're on file, and my parents did. So I'm part of their care. When they pass away, if I want to know something, they don't need an authorization to do that. They can just refer to that documentation that was already on file that recognized me as part of my parents' care, and you can release the information to me, right? You just have to be able to prove that that relationship existed before the person expired. Okay, so you don't have to get something in writing from them anymore, but you have to be able to point to something that says, we recognize that this person was part of their care, however you do that. Okay? Student immunizations. Is this a state where the state has a law that the hospitals have to release immunization information to the schools? Do you know? You don't know? Probably not. I live in a state where they do, right? I live in a state where there's a law on the books that says the hospitals have to send immunization information on children to the school. They're required by law to do that, okay? If you, not all states are like that. If you live in a state that has that type of law, you no longer have to get an authorization from the parents to give that information to the school. You can provide immunization information to the school for their students, right? Based on that law. So it makes it a little bit simpler. We don't have to have the parents come in and sign something. You can just release it. Genetic information. This really is not a change. The only difference is that they brought GINA under the umbrella of HIPAA, right? So certain types of information had been segregated for whatever reason. So for instance, you guys know that genetic information fell into a different category. Mental health, substance abuse information is in a different category, et cetera, et cetera. That information is now all considered part of or underneath the umbrella of the HIPAA privacy and security protections. So the GINA, under the GINA Act, what it says is health plans for underwriting purposes cannot deny me coverage based on something that's in my genetic profile. Right? So if my family has a history of men having heart attacks by the time they're 80, you can't deny me health coverage because I'm 79 and I'm about to hit that threshold, right? Or I'm on the list. Okay? So they can't do that anymore. You can't look at that data and do that. The SAMHSA, which covers substance abuse, mental health, security issues, the Common Rule, which covers research, etc., are going to come out with changes on those rules either later this year or early sometime next year. And those, just like GINA, are going to actually be brought under the HIPAA umbrella. And so the same protections that we now have for PHI will be applied to that information as well. So right now, for instance, the Common Rule, which deals with research data, if you as a covered entity give PHI to a research organization under an IRB, right, under a legitimate IRB arrangement, if they have a breach of that information once they have it, who do they have to report to? Pardon me? That's it. That's the only person they have to report to. The IRB board, right? Period. They don't have to report to you. They don't have to report to the patient, to the individuals. They don't have to report to the media. They don't have to report to HHS. They only have to report to the board. It's the same information, though, that you've got 3 blocks away in your system. And we've had multiple high-profile breaches in research facilities and academic medical settings where they lost the data and it actually fell back on where the institution that the data came from, and yet it wasn't their breach. And obviously it's gotten a lot of notoriety in the sense that the hospital that's right here, if they have a breach, they have to notify everybody. And this guy over here, who's 2 blocks away, because he's a research organization, he loses the same information. He doesn't have to report to anybody. So that's not really from a consumer protection perspective, that really doesn't make a lot of sense. So one of the things they're looking at is changing both the Common Rule and SAMHSA, and they've already changed GINA, to bring them in under HIPAA privacy and security and apply those protections to that data regardless of who has it. Okay. Next part of the privacy changes dealt with rights of access and requests for restrictions. So it expands the right to an electronic copy of any PHI stored electronically, and this is the difference, in a designated record set. Okay? How many people remember the designated record set? Where did you first hear of it? In the privacy rule, right? That's where you'll find it. It came out in 2003. Most organizations haven't thought about their designated record set since 2003 when that rule came out. Why? Because nothing else was focused around that at all, right? And for the most part, as it relates to accounting for disclosures, etc., TP&O, right, information was exempted. Didn't have to report that. Under the new rules, under the high-tech rules, accounting for disclosure, which will come out later this year, TP&O is reportable, and now that designated record set becomes more important. So what you're seeing is other changes and other rules that are tied together. And this one here, with respect to the designated record set, what they have done is they've said that there are a set of core requirements around our EHR, EMR, at the core of our data. And then outside of that is this next ring of systems that we call the designated record set, right? Which are any system that is involved in the decision-making process with respect to treatment, payment, and operations. And then outside of that is the larger ring of all systems in our environment that have protected health information in them. Now what you're going to see is that there's going to be more and more focus on the designated record set. In fact, when you look at the new accounting for disclosure rule, it doesn't address all systems with PHI like the original rule did. The original accounting for disclosure rule said any system that has PHI in it, you have to account for disclosure, right? Under the new rule, which will come out later, it basically says that you have to account for disclosures from the designated record set. So one of the things that you need to do is rethink about what is your designated record set for your organization. Okay? Now, if you are not quite clear on what that is or how to figure that out, there is an organization that the academic medical centers kinds of runs, and I talk at their meeting every year, called NCHICA. How many folks have heard of NCHICA? Okay? So it's North Carolina Health Information. I don't know what the last two stand for. But anyway, what it is a gathering of the academic medical centers around the country that Duke University actually sponsored, and that's why it's called NCHICA, because it comes out of North Carolina. But what they've done is they've actually put together some really useful products for folks in the industry. And one of the things that they put together was kind of a workbook, if you will, for how to figure out what your designated record set is and how to identify that. So you can go to the NCHICA website, NCHICA website, and you can download, and I forget the exact name of it, but you can download their white paper or their whatever they call it for the designated record set, and it'll actually take you through a step-by-step process for how to figure out what your designated record set is. Okay? It's NCHICA. And I think it's nchica.org, but I don't know exactly. Now, here's the trick. You want to make that designated record set at what? Small as possible. Exactly. So, if information comes from an ancillary system, right, and ends up in the EHR, I don't need to include that system as part of my designated record set, because I can rely on my EHR for what? Decisions. If there is a system that is not included, where the data is not included in my EHR, right, but I need that system as part of my decision-making process for treatment, payment, or operations, it needs to be part of my designated record set. So, for some large hospitals, for instance, that have gone the route of Epic, if you're familiar with the Epic system, which is one of the few fully integrated systems from start to finish, their designated record set and their EHR are what? One and the same. Okay? For those organizations that still live in a best-of-breed environment where they have Lawson for financials and McKesson for clinicals and GE Centricity for ED and whatever, you know, yada, 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 guess what? Their designated record set just got bigger and bigger and bigger. And if you have a separate pharmacy system and a separate lab system and a separate PACS system, all that's part of your designated record set. So you want to have as few systems as possible in that designated record set, because those are the ones that you're really going to have to keep track of.
So that pharmacy data, that pharmacy system is just going into my EHR, and the pharmacy system
It's not part of my designated record set.
doesn't actually use the
And that I have to have for decisions. right? So anyway, that's the key to it. But if you download that paper, it'll help you walk through that. The preamble of the rule states that entities will not need to invest in additional technology to meet this requirement. So what they're saying, or what they believe they've done, is they've created a situation where all of these changes that they've made with respect to access rights and restrictions are not going to require us to have additional technology to be able to make it work. Why? Because the changes that they've made, for the most part, are changes that the EHR vendors, or the EMR vendors, are going to have to implement in those products. So when we look at the upgrades to those products for meaningful use stage 2, et cetera, we're probably going to start seeing some of the changes that are going to be required in the Omnibus Rule as well, because otherwise we're not going to be able to meet those requirements. An individual has a right to direct information be sent to another individual, and they don't have to necessarily do this in writing. In other words, they don't have to fill out a form, but you have to know exactly who it is that the information is going to and an exact address that it's going to. So if it were me, they'd be filling out a form and putting the name down, and they'd be putting an address down, and they'd probably be signing it. But you can do it whatever way you want. They can, the bottom line is there's certain information that you have to collect to do this, but as a patient, I can say, I want my oldest daughter to receive this information, right? But I have to tell you who she is, her name, and I have to tell you the address to send it to. Okay? Information may be transmitted. Now, this is kind of a tricky one. Information may be transmitted using unencrypted email so long as the entity warns the recipient of the risks. So, why do you think they put that in the Omnibus Rule? What does HIPAA say about transmitting PHI over an open network? It says you can't do it unless you encrypt it, right? But if the patient says, I want you to send me my stuff through my email and don't encrypt it, you're kind of caught in a catch-22. If you do what they tell you, you violate HIPAA, right? If you don't do what they tell you, they get upset with you. And it's their information, so why shouldn't they have the right to say, I don't care if you send it unencrypted? So basically what they did in the Omnibus Rule was they gave the patient the right to allow you to waive the requirement to encrypt their data. Make sure you have a way to capture that request. Now again, there's nothing that says it has to be in writing or that they have to sign it or anything else, but my suggestion is that if somebody says, I want you to send my information to me unencrypted, you get it documented somehow, whether you document it or whether you have them document it, but make sure you document it. Because sometimes they'll forget that they told you that, right? So we all know how that happens. Provides 30 days fewer to provide off-site information. So under the old rule, if you recall, if you had information stored off-site in an archive or in a long-term storage or what have you, and you had a patient who requested information or somebody else requested information on a patient and you had to provide it, you had up to 60 days to provide that information because they took into consideration the fact that you were going to have to go somewhere to get that data, right? Under the new rule, it basically reduces that, but it puts it in the 30-30 category, which is the way they've treated all these things now, which means you have 30 days to do it, or you have to request an extension for another 30 days. So there's just something important that you need to make sure folks understand, that when they're dealing with this, if you don't get it done within the 30 days, you have to request that extension. Okay. It provides a right of restriction for disclosure to a health plan if an individual pays in cash and in full and requests it. So if I go into my doc and I say I want a vasectomy, but I don't want Mrs. McMillan to know, so I don't want my health plan to know, right? Not saying that I would, but you can see where that would happen, right? And I say I'm willing to write you a check today in cash, in full, you have to respect that restriction, And you have to restrict that part of my record and not allow anyone to see that information to include my health plan. Okay? Now, it's not just for that reason. It could be for any reason. Bottom line is, if I'm willing to pay in cash, I'm willing to pay in full, and I tell you I don't want my health plan to know it, you have to restrict it. Now, that's a real problem for some of our healthcare entities, covered entities, because many of them have their own health plan where they cover their own employees, and typically they have a TPA who is the health plan who supports them, and a lot of times that TPA has direct access to their information, or has, even in large systems, actually has people on site who have direct access to their information. And so now they're having to deal with the fact that if an employee does the same thing, they have the same right? And if they request that restriction, you have to make sure that that TPA, or anybody working for that TPA, does not see that information. Okay? Or if you have a health plan that is in support of your organization and they have access into your EHR or your EMR, you have to make sure that they don't see that information. Now, I'll tell you that that's a real problem. And this is probably the most difficult requirement in the entire Omnibus Rule, because most of our EHRs, EMRs today don't give us the capability to restrict access to just a part of my record to certain individuals. So I either have to change the process that I have in place with my TPA or with those health plans such that they don't have direct access, so that I can ensure that they don't see that information, right? Or the vendor eventually has to provide me with a system that is capable of doing what we call limited data set. And I can tell you right now that most of the vendors, EHR and EMR vendors, are not even ready to go there, because that's a total rewrite of their code. Okay? Places responsibility for telling subsequent providers of this restriction on the individual, not the hospital. So that's actually a good thing. So basically what that means is that you have a responsibility to protect or restrict access to that information in your system. But if there's a downstream provider or somebody else that's involved in this person's care, so for instance, if I came in, had a procedure, and then after the procedure had to go see another specialist or whatever afterwards, right? It's not your responsibility to tell the specialist that they have to provide that restriction. It's my responsibility to tell every provider involved of the restriction that I want. Okay?
How does that work for example, pathology? You don't realize that the pathology isn't on the hospital.
So you have to inform me that there are other providers who will be part of my care that you do not have a responsibility to tell this restriction to. And then I can say, well, who are they? And then,
the fact that you sign a consent that may state that there are other providers that may be involved in the care.
that's still, you can't assume that I understood what that meant, right? Okay? Now, in most cases, I'll be honest, in most cases, if they are directly involved, I would probably tell them, inform them. I would still inform the patient, but I would inform them as well, because I would be a good neighbor and tell them what's going on so they don't end up on the wrong end of an issue. But the point is, you don't have a responsibility to do it anymore. Right? Basically what the government said is that's not fair to the provider that they have to go tell everybody that's involved, because some of them you may not have direct interface with. Right? Okay. We also have to update our notice of privacy practice. If we are a health plan, which I don't believe anybody in here is, but if we are a health plan, they actually changed the rules with respect to distributing notice of privacy practice for those folks to make it simpler and less costly. So under the current rule, if they come out with a change to their notice of privacy practice, within 60 days they have to send a renewed copy to everybody that's a subscriber. That's a huge cost to those folks. Now what they have to do, what they can do, is that under this rule, is when they come out with their new notice of privacy practice, all they have to do is post it on their website, and then when their next annual communication comes around, right, which usually once a year you hear from your health plan, they can include the new notice of privacy practice in that annual communication, which reduces the cost for them. For the provider side, it doesn't change. The same rules are in effect with respect to how we distribute notice of privacy practice. That notice of privacy practice, though, now has to have this information added to it. The duty to notify individuals of breach of unsecured PHI. In other words, you have to tell the patient that you have a duty to tell them if their information is breached. You may not refuse to restrict access to a record when the patient pays in full or in cash. You have to tell them that they have the right to ask you to restrict that access to their health plan. That plan's restriction from using or disclosing genetic information for underwriting purposes is not allowed. So they understand that if they have a genetic test of some sort, that cannot be used against them with respect to insurance. Deletion of appointment reminders or treatment options, types of and uses of disclosures requiring authorization. So you have to address the marketing, the sale of PHI, and they added psychotherapy notes down here, which I'm not quite sure why, but because they didn't talk about it anywhere else, but they said that's one of the things that we have to put in our notice of privacy practice. You don't have to put that in there anymore. Under the old rule, you had to basically put information in there with respect to changes to appointments and that sort of thing. You don't have to do that anymore. That's not considered part of privacy.
Back on
Mm-hmm.
right? I'm thinking most of us are hospitals.
Right.
It's so hard to get that paid in full cash paid when the patient walks out the door because the bill is pretty good.
So this is one of those things where you're going to have to revise your admitting process, right, to ask the patient, is this something that you want to restrict access to from your health plan? And if so, you need to pay in cash and in full for this service.
But we don't know how much they're going to owe. Again, for that necessity, depending on what
That part I can't help you with, right? But the point is, you have to tell them that they have the right, and you're right. It's up, I would want to have to get that. They would have to request that restriction up front. Trying to catch it at the tail end is not going to work, right? So you want it to happen when they come through the door. I'm guessing that most people that are trying to, and I won't use the term hide, but hide something, probably are going to tell you right away, right? I mean, if I come in there and I don't want somebody to know why I'm there or that I'm there, I'm probably going to tell you that when I first walk through the door, I don't want anybody to know I was here. And at that point, you're going to say, well, Mr. McMillan, pull out your checkbook. Okay? And we'll hook you right up because we like paying customers.
So you're not advocating making this a standard function?
No. You don't. You have again, as part of your notice of privacy practice, you have to inform them that they have this right. If they don't read the darn thing, that's not my problem, right? But you do need to make sure that it gets in their hand. And we're going to talk about audits in a minute. I mean, that's one of the big issues we had in the audits this year was that people are not following their procedures, right? And I mean, literally, I went into I took two of our youngsters out. I do that all the time when we hire young people. I always go out with them on one of their first trips because I kind of sort of want to show them what I expect of them. And so I went out with them, and we went to this one hospital, and we went over to the clinic, one of the clinics that was associated with the hospital. And we walked in, and one of the first things I noticed looking around was that there was no notice of privacy practice or no mention of a notice of privacy practice anywhere in this clinic. Right? So I walked up to the nurse or the young lady at the glass window, and I said, treat me like a brand new patient, like I've never been here before. Give me the clipboard, right? We've always got a clipboard. Give me the clipboard. So she gave me the clipboard, and I went through all the documents on the clipboard, and lo and behold, one of the things on that clipboard was a receipt that I had received the notice of privacy practice. But conspicuously absent from that clipboard was the notice of privacy practice. So I said, I got a problem. I can't sign this receipt because I can't find the notice of privacy practice. And she said, oh. And I said, so could you give me the notice of privacy practice? Well, this young lady looked all over and couldn't find a notice of privacy practice. So I said, go get your practice manager. Go get the administrator for the clinic. Went and got her. She came out. I said, you know, I want to sign this receipt, but nobody seems to be able to give me a notice of privacy practice. She looked. You think she could find it? No. So I said, go get the doc. I'm becoming a real pest at this point. So she goes and gets the doc. The doctor comes out, nice guy, been there forever. I said, Doc, I said, I'd love to sign your receipt that says I've received my notice of privacy practice, but I said, none of your staff can produce it. Can you produce it? He had no clue, of course, where it was at. I didn't expect him to, by the way. I just wanted to go through the whole organization. And I said, guys, I said, this is what we're talking about. This is what gets you in trouble during audits, right? Because they look at your policy and your procedure, and you clearly have one that says you give it to patients when they come in the first time. Your clipboard even asked me to sign for the darn thing. But yet you can't put your hands on it to save your life, which tells me that probably it's not up to date either, right? So that's a pretty common occurrence, unfortunately. All right, let's shift gears, talk about business associates. The rule doesn't really change what business associates are responsible for. What it changes is the fact that they're now liable directly, right? So OCR, who I guarantee you is chomping at the bit to go after business associates after September, and they are, because they're convinced that a lot of the ill that we have in healthcare as it relates to breaches and whatnot is literally squarely on the shoulders of business associates. And in the past, they haven't had the authority to go after them, and now they do. And so they're gonna do that. But basically, it also clarified the definition of what a business associate is, because a lot of companies out there will tell you, I'm not a business associate because I don't look at your data, or I don't handle your data directly. I just host it here, or it just flows through here, or all I'm doing is hosting your mail, or whatever. They are absolutely business associates, and it's real clear now. If you create, if you receive, if you maintain, if you transmit PHI on behalf of a covered entity, you are a business associate. So ISPs that host your mail, hosting centers that host your servers, ASP vendors who host applications for you, cloud vendors who provide services that have PHI in them for you, anybody who receives PHI from you or who has access to your systems with PHI is a business associate. That simple. Now, one of the things that you need to do before September is go to finance and pull your AP report and look at all of the people you're doing business with and re-examine whether or not you should or should not have a business associate agreement in place with them. I will tell you that this is what OCR does during their audits, and it's what we do when we go in and look at folks, and we always find contracts with vendors or consultants where there is access to PHI or there is some service being provided with respect to PHI and there is no business associate agreement. Okay? And the larger the organization is, the more egregious that becomes. But you want to do that. You want to go in there right now with the change of the rule, do that one-time audit, if you will. Make sure you've identified everybody that you need to have an agreement with, and make sure you get those agreements in place. Now, the rule also identifies subcontractors and other organizations as being business associates as well. They, though, are not your responsibility. They are the responsibility of the primary business associate. So whoever it is that you've got the contract with, if they turn around and give part of that process to someone else, right, that's a subcontractor, they have a responsibility for giving that entity a business associate agreement, not you. Okay? But the business associate agreement follows the data as far as it goes. It could be 5 or 6 subcontractors down. It doesn't matter. However far that subcontractor relationship goes, that contractor each way along the way has to give that next one a business associate agreement. Okay? Omnibus makes BAs directly liable for the entire security rule and parts of the privacy rule. It also makes covered entities and business associates responsible for the actions of their agents. Real important. So individuals who do things for you can be actually in 3 categories. You can treat them as workforce members, right? So if you have independent consultants doing something for you, you can treat them as a workforce member instead of a BA, and you have to train them, you have to give them your policies and procedures, and you essentially direct them, and they report to you, and they're responsible to you. Or you treat them as a business associate, and you give them a business associate agreement, and then they are responsible for their own training, et cetera, et cetera. Or you can name them as an agent. They have to be a business associate, of course, as well, to be an agent, but it's real important because this agent designation makes you responsible for what they do, right? So unless you really need them to be an agent, you don't want them to be an agent because it's additional liability for you. You want them to be responsible for what they do. They may actually want to be an agent because they know that that puts the liability back on you, right? So think about that very carefully. Omnibus reminds covered entities to use business associate agreements, but makes it clear that business associates are liable regardless. So they made it really clear in the rule that whether you give them a business associate agreement or not, whether they agree to sign it or not, whether it's been updated or not, it doesn't matter if they receive, create, transmit, maintain PHI, they are a business associate. And the federal government will treat them that way. Now, if you have not given them a business associate agreement, they're also going to come visit you, right? So they're going to go after the vendor with respect to the breach or the incident and whatnot, but then they're going to come back and they're going to cite you as well for not having a business associate agreement in place. And when they do that, they're probably not going to come back and just look at that one element of your program. They'll look at your entire program, which is the way they operate today. Okay. Real simple. You give them a deadline, and you say, if you do not sign it by such and such a time, we will terminate this relationship, and we will report you to OCR. And that's what the rule says you're supposed to do.
So what about these vendors that include business associate language in the contract itself? Not including PA, there's a section of language.
Okay. You are responsible for giving them a business associate agreement. They are not responsible for giving you a business associate agreement. So if a vendor tries to give you their business associate agreement, which I guarantee you will be written to limit their liability, right? Don't accept it. They have to sign your business associate agreement. Now, if you read their business associate agreement and it's actually as good or better than yours, then maybe you would want to sign it in that case. But the point is that you need to look at it, and if it doesn't meet your standard, you give them yours. Because some of the things in your business associate agreement, which I guarantee you will not be in theirs, are things like indemnifying you for the cost of breach.
So should we be taking out that language out of that contract when we have one VA, or are we, because if we have two and they conflict, the one in the contract and the one we want them to sign?
The one that matters is the one that you give them, because it is they're signing your agreement. You're the covered entity, they're the business associate, right? But I would take it out. I would have it taken out. I would say you will use our business associate agreement, or you will adopt our business associate agreement. I don't care which way you do it. You can make ours part of yours, or you can use ours. Either way. Now, OCR did publish a new business associate agreement template on their website after Omnibus came out. So if you haven't updated your business associate agreements yet, and you want to take a peek at that before you do, you can go to their website and download that template and look at what they recommend be in an Omnibus approved business associate agreement. Okay? Keep in mind, you're in the driver's seat. They're wanting to do business with you. Now, I know somebody in this audience is sitting there going, this guy can't possibly have worked in healthcare for 13 years and think that a critical access hospital can tell some of these companies what to do. Right? Bull. Okay? Now, the point is at some point, you're going to have to adopt some of those positions, because if you don't, you're taking on that risk. It's just that simple. The federal government, OCR, does not care that you are small. That is not an excuse for not following the rules. They don't care that you don't have money. That is not an excuse for not doing anything. Okay? There are 12 organizations out of the 115 that were audited last year that are being investigated right now because of willful neglect. Just so you understand that. Okay? They're serious about it. You know, and what you got to hope for, and I'll tell you, at some point what you're going to see, and I think we're seeing it, we're beginning to see it now. The larger health systems are beginning to plow that field for us, right? Because they are now telling the vendor, no, you will sign our business associate agreement and you will agree to these things. Generally, what they're having those guys sign and agree to is far and away much harder than what you're going to require of them. So generally, it should be fairly straightforward for them to sign your business associate agreement, because many of those larger systems now are actually requiring vendors to go through independent assessment. They're having them fill out all kinds of questionnaires, having them go through audits each year, et cetera, et cetera, et cetera. Things that you're probably not going to do because you don't have a department that's focused just on vendor management, right? But the point is that when you say, I need you to sign my business associate agreement, that shouldn't be the first time they've heard it, unless they're a local, regional player, right, and they haven't done a lot of work in healthcare. Okay? But if they want to do business, they need to get with the program.
With regards to the business associate agreement, can you address the possibility that
What do you mean?
hospital.
No, it doesn't affect that at all. Okay. No.
Drafting two versions of VAs and saying, either you sign this one, or if you don't, this is the one that I'm going to give to OCR when they show up and say,
Yeah, there's another trick. Basically, you draft, and I wouldn't do this, but you can if you want to. You draft two BAs, one that is very restrictive and one that's probably reasonable, and you say either sign the reasonable one, or if you don't, this unreasonable one is the one I'm going to give OCR that you failed to sign. Okay. I'm not into playing games. Bottom line is, you give them your agreement, they either sign it within a reasonable period of time, or you sever that relationship and you report them to OCR. Now, I will tell you that telling them that you are going to report them to OCR is probably all you're going to have to do. Because if healthcare is an important part of their business, right, the last thing they want is for OCR to come knocking on their door to run an investigation. And to potentially, if they're not signing your business associate agreement, they're probably not signing your neighbor's business associate agreement as well, right, or others. So if you, whichever one of you gets to them first and reports them first, when OCR comes in to look, OCR is going to ask them for every covered entity that they're doing business with, and they're going to ask them to produce a business associate agreement for every single one of those entities. And for everyone that they can't produce one, OCR is going to go to that covered entity and say, why haven't you given them a business associate agreement? And if those entities say, well, we did, in fact, we have, and we've been negotiating it with them for 6 months or 9 months or whatever, and they've not signed it, guess what? That business associate is going to get handed a hefty fine. Because that means that they've been receiving PHI for some period of time, and the covered entity has tried to do what they need to do, and the business associate has not lived up to their responsibility. And they can be fined for every single instance. So think about it. So it's $1.5 million per instance. So if they haven't signed 30 BAs, it's 30 times 1.5 million. Now, OCR is very reluctant to fine hospitals, particularly critical access hospitals, those kinds of numbers. You think they're going to be that sympathetic for a for-profit corporation? I don't think so. I think we're going to see much bigger fines when they start fining business associates, especially when they start hitting people like McKesson and other people who make millions on this industry.
Does your company review like the vendor list and what is decent, what does qualify? Because sometimes, like you said, you get those things, you think, we can sit there and think, yeah, they've got access, we should sign it, but then they send something from their own legal team saying they don't have to sign it because, and then we're kind of getting in that, well, what do we really need to do? We're not attorneys, but, is that something, I mean, we can send it to our own legal counsel, but they're not always as
clear on what the rules are, yeah. Yeah, we can do that, and if it's just something simple like that, we don't mind doing that just for you. So no, I don't. Yeah.
Well, I'm even talking about like an engagement. Do you offer those?
We do. We have well, I don't usually talk about services at these things, but anyway, we have a vendor management service that we offer to organizations where we actually help manage that process and interact with the vendor, and so we request all the information from them that you probably should be getting, in most cases are not, right? And go through that. But Adam can talk to you about that offline if you're interested. But if you just have a question, and anybody just has a question and you want to ask it anytime, just feel free to ask it, and we'll answer it. Okay? All right. What part did I not cover? Nothing. Oh, the timelines. So, any vendor agreement, remember what I said at the beginning, any vendor agreement that was in place prior to January the 25th, you have until 2014 to update. Any vendor agreement that is either renewed, revised, changed, brand new, etc., from this point forward has to meet the new requirement and has to be in place prior to September the 24th of this year. Okay? All right. Business associates must observe the rules regarding uses and disclosure. So this is what they got told they have to do. Must make notification to the covered entity in case of a breach. So they still only have to notify you. They don't have to notify anyone else. But it's real important, of course, in your business associate agreement or in your contract somewhere where you tell them how much time they have to report to you. You're the one that has the responsibility to report within 60 days to the individuals, to the media, and to HHS. So you can't give them 60 days, right? Most healthcare organizations today give the vendor anywhere from 2 to 4 days, period. Meaning once they know of a breach, they report it immediately. That way we have time to get ready for all the rest of the notifications, as well as to participate in the risk assessment process that has to be performed. Must provide an e-copy of PHI if requested as specified in the contract. So they are part of your accounting for disclosure universe now. It extends to your business associates, right? Particularly if they're providing any service that's related to your DRS. So they have to be prepared to assist you in providing that if requested. Oh, absolutely. You don't leave any wiggle room. No, they report it to either the, well, in large organizations they report it to the compliance officer. If you have a compliance officer that's fine. If you don't, then report it to the administrator or report it to somebody senior enough in that organization to handle it. Must disclose PHI to HHS when conducting compliance review or investigation. Now, you ought to know if they're being investigated anyway, right? Because they should have reported it already. But maybe not. They could be audited, or they could be investigated for some other reason and asked to provide PHI as part of that investigation, and they're obligated now to provide it. If it's my PHI, I want to know that, right? So you need to have something in your business associate agreement that says, when requested by HHS to provide protected health information that belongs to this covered entity, you will notify us before you do that, right? Now, you can't stop them from doing it because they have an obligation to do it, but you want to know about it, right? You want to know if some of your information just went to San Francisco or went to Washington or wherever it went to. Must provide an accounting for disclosure, and that'll come later in the year when that rule comes out. It'll cover what that means, and must comply with the HIPAA security rule and certain provisions of the privacy rule. Okay, enforcement. Last part of the Omnibus Rule. So, obviously, the civil monetary penalties as well as the criminal penalties now apply to them. The Omnibus Rule retains the definition of willful neglect as conscious, intentional failure or reckless indifference to the obligation to comply. And the examples they always give are anything that's in the rule and you haven't done it, that's willful neglect. You consciously decided not to comply. It's that simple. Rules have been out since 2003 and 2005. If you haven't had time to read them, you need to make time for it. Okay? I will tell you, though, under the audits, the number one answer that was received for noncompliance was, I didn't know I was supposed to do that. We actually had people who said in audits, I didn't know we had to do a risk assessment. Now, I realize I was an Aggie and a Marine, and we're not as fast as everybody else. But even I know that we're supposed to do risk assessment in healthcare now after 13 years of doing this, right? So how can you really say to the auditor, I didn't know that was a requirement? And what do you think the auditor's response to that's going to be? Right? It's total neglect. And lest we forget, guidance for de-identification of PHI recently came out. Guidance for mobile devices has come out. The accounting for disclosure rule is coming out later this year. The Securing America's Health Act, which is the Franken legislation, which is a reaction to the accretive affair, is out there, and I'll talk about that a little bit later. Meaningful use stages 2 and 3 are already out. 2 is already out there, and we're going to have to comply with that come January. 3 we've already seen, right? And it takes us to two-factor authentication for any system that touches the EHR. We're going to see how that works out. The National Cybersecurity Act and the executive orders around that, it actually talks about healthcare. And of course, state legislation, the states are getting really active. The state of Minnesota is now adopting all 6 of the California statutes on privacy and security and breach notification. Several other states, Texas just passed SB 300, which is a very far-reaching piece of legislation as it relates to privacy and health information. We have more strict requirements now in a lot of our states than we do actually at the federal level. Right? So the requirements just keep coming. Okay. Any questions on any of that, the Omnibus Rule, before we take a quick break and move over to audits? No questions? If you have one later, just grab one of us and ask. Okay? Can we take a quick break for folks?